Good morning. Welcome. Thank you so much for taking the time to join us today. My name is Coral Owen. I'm the Professional Development Coordinator for the Military Families Learning Network. In case you're joining us for the first time today, I'd like to give you a brief tour of our webinar platform so you can find your way around. Hopefully you're currently able to view the slides that we're sharing. If you can't see them or have any other technical difficulties today, you can send us a tech support request via email to mfln@gmail.com. We look forward to having you join us in the chat pod today for conversation and for questions. If you'd like to say hello and let us know where you're joining us from today, we'd love to hear from you as well. To embed the chat so you don't miss any links or conversations, simply place your cursor over the shared slides. You should then see a toolbar pop up across the bottom of your screen, and then from there you can select the chat bubble icon. When typing your comments and questions, please be sure to select the All Panelists and Attendees Response option from the drop-down menu that's located right above where it says Type Message Here. This just ensures everyone who's on today's webinar is able to view those comments and questions as they come through the chat pod. We'll also be covering evaluation and continuing education information at the end of today's session. The Military Families Learning Network is part of a DoD-USDA partnership for military families, and our passion is to connect military family service providers and cooperative extension professionals to research and to each other through innovative online programming. It's my pleasure to now turn things over to my colleague, Rachel Browner, with the Mfln Military Caregiving Team to introduce today's speaker.
Welcome everyone, and thanks for joining us. Just before we go ahead and get started and I introduce today's presenter, I wanted to let you know that we'd love to hear from you throughout today's presentation. So if you have any questions or comments, please use your chat. That's a way that we're going to be able to communicate back and forth with our presenter and our team. So please feel free to use that option, that chat option. Also, to make this a little bit more of a personable platform and connect with one another, we'd greatly appreciate it if you let us know where you're joining us from. Normally in these presentations, we have folks from all over the US, and so we'd like to get to know you a little bit better. So if you can, please type in the chat pod where you're located, where you're joining us from. If there's more than one of you in your office that's listening in, let us know. We're glad that you guys are on today, and we're looking forward to today's presentation, especially since Dr. Carly McCord is going to be presenting. Dr. McCord is a licensed psychologist and the director of telebehavioral care at Texas A&M Health Science Center. Dr. McCord is also a clinical assistant professor in the departments of psychiatry and educational psychology. She has a proven and documented expertise in providing high-quality mental health services, long-distance technology, engaging in rural communities to reduce mental health disparities, and starting a successful and innovative training and supervision model for telepsychology. She systematically studies the mental health needs of clients of the telebehavioral center and the communities in which they reside, develops and refines intervention approaches, investigates the effectiveness of intervention, and evaluates satisfaction with services. In both research and practice, Dr. McCord is well-versed in underserved population, training and supervision, and telehealth. So without further ado, we're very excited to have Dr. McCord on presenting, and I'll pass over the presenter aids to you now, Dr. McCord.
My mute button shifted over to the right. Howdy. Good morning, everyone. Here from Aggieland and College Station. I see a shout out from Puget Sound, VA. We actually have a former telehealth student from here at Texas A&M, Dr. Kelly Caver, over in your neck of the woods. So I'm really excited to be with you guys today to share some of my expertise and experience in telehealth. The title of today's talk is A Primer in Telehealth Services for Providers, Caregivers, and Individuals with Special Needs. So this will be a sampler platter or a charcuterie board of sorts of all of kind of some of the different topics that I often teach and talk on. We'll do kind of a high-level overview of all of those. And this was certainly a challenge to try and think about making this talk relevant to so many different pockets of individuals, but I'm glad to be here with you today. I want to start a little bit and just tell you who I am and aside from my very formal, very long bio. Thank you, Rachel. So you know what I do and what I don't know about telehealth. So I was lucky enough as a graduate student here at Texas A&M to be on our very first telehealth pilot out to Centerville in Leon County. You can see that's quite a bit of ways from College Station, where Texas A&M is located, and that is one of many counties in Texas that has 0 psychologists. Actually, over half of Texas counties have 0 psychologists or 0 psychiatrists. We have the greatest proportion of individuals living in mental health professional shortage areas. And we saw telehealth as a way to increase access to services. So our services, I'm a psychologist. Everything we do is primarily behavioral health. However, I've tried to have the presentation include different elements of telehealth in general, but that is where my expertise lies. Over the last 11 years, we have built out access points all over the Brazos Valley region, which is about 90 miles from Houston and 90 miles from Austin, smack dab in the middle. And we have both hub and spoke telehealth, which we'll get into that in terminology. We also, now that technology is advanced, have direct to consumer where you can log in from any mobile device. And we've partnered with community resource centers, primary care clinics, schools, and jails. So really wanting to get in this community and have access to mental health kind of in every important pocket to really try and create better health for our community. We're a training clinic. So most of my therapists are doctoral students. Keep an eye out for them if you work at a site that takes interns. Hopefully we can send some good folks your way. Again, we're going to go over quite a few different things, modalities and applications, benefits and risks. We're going to get a little bit into effectiveness, what the literature says. We're going to hit laws, ethics, and guidelines, and just some recommendations for future practice. Okay, so telehealth at its most basic, tele-distance, health at a distance. The earliest that I can even fathom telehealth being a thing would be the use of bonfires and the bubonic plague to communicate to communities nearby when an outbreak had happened. And beyond that, moving into Alexander Graham Bell and the use of the telephone to assist with different speech impairments. Then to the development of Morse code and using those on Navy ships to communicate health information back to shore and get advice from shore back to the ships. As technology has advanced and as needs have arisen, often a crisis or a war, we see these huge, sometimes leaps forward in how we're using technology for health. And I think we've all been living that in this last year and seeing the boom of telehealth through the COVID pandemic. And I'm here to tell you that it's here to stay. So telemedicine, telehealth has a history of reaching, monitoring, impacting, and managing. I want to just throw out some of the latest and greatest technologies that are available as part of this. So how many of you knew that more people have access to a mobile phone than they do have access to clean water or a toilet? That was pretty shocking to me, but I think it says a lot about our ability to reach people through technology that, sorry about that. Let me mute all of my devices. I did close all my email stuff down. Okay, so lots of opportunities to reach folks now with technology being so available. Fitbits, how many of you own some kind of device that tracks your steps or your heart rate or your sleep? These are becoming more and more and more common, and more opportunities to communicate that data back to providers, which is pretty exciting. So we have a proliferation of wearable devices. This is a project that I'm working on here at Texas A&M with our College of Engineering. They have done this work with veterans, and now we're replicating it with college students. Again, these devices have a lot of sensors and data available. Heart rate. Did you get up and walk around? Accelerometers. Oops. Whoa. Goodness gracious. How many steps you took. GPS, light sensor. All of that can be gathered and built into algorithms. You can have, aggregate algorithms for large samples of folks where we get better understanding of anxiety and stress response and health behaviors, and then individual algorithms for folks. So in this project, helping students be able to identify critical moments of stress and anxiety, and then linking them directly to this mHelp bundle, which is a app that they're developing that's also connected to crisis services, access to our counseling services on demand, and other kinds of supports. So lots of promise there. This is one of several different models of telehealth pill dispensers that sometimes can even be connected to family members, connected to providers, where they can have this. This particular model has built-in screen for telehealth sessions, and then a way to help manage medications for a variety of reasons, to be able to help ensure adherence, and then even the medications that are being developed with some ability to tell if the person's actually ingested the pill, if they're actually taking it. Want to expose you guys to this, the future of holomedicine, and I do believe that this is on the horizon and something that we will see.
At Silverchain, our vision is to deliver the world's best health and aged care in people's homes so they can live their whole lives as they choose. We know that Australia's demand for healthcare is increasing, partly because of an ageing population, but also because of the increased number of things we can do in hospitals. And our research shows that about 30% of people in Australian public hospitals today don't need to be there. And we know we can deliver them really high quality care at home. Now, this will not only increase the safety, increase the convenience, and be what people prefer, but it will relieve the pressure on our public hospital system for people who really do need that level of care. Our new technologies allow nurses who are on a day-to-day basis responding to clients in their home to be able to have really good access to the data, be able to have their hands free while they're reading data, but also importantly consult with a doctor and have the doctor see what the nurse is seeing and the data at the same time as giving the nurse advice about how to treat the patients. This significantly increases the capacity of the nurse to practice at the top of her profession, and it gives the doctors an incredibly efficient way of being in many places at once. Enhanced Medical Mixed Reality, or EMO as we call it, creates a hologram of a doctor. So the experience is a doctor's really personally in your home, talking to you, in dialogue with you, looking at you and consulting with you about your healthcare. So the experience is a doctor has come to your home and visited you. We think this is going to meet the demand for increasing healthcare for our community in a way that's not only less expensive, but is much closer to what people want and takes the pressure off our hospitals for the future. It's part of our vision for a new generation of healthcare for Australia, and it's coming soon.
Yes, how cool is that? And I can't say how far off we are from those. I think each of those technologies and pieces exist. How well it can be replicated and used widespread. We're generally pretty bad at predicting how quickly things are going to happen in technology. I think what you'll see most often is this kind of setup. But some of the same ideas of when you can't get a physician or a provider or a particular specialty, that you can have some level of support, boots on the ground, working at the top of their license and being coached and evaluated by someone on telehealth. One of the things that we're doing here at Texas A&M and our College of Nursing, we have a very, very limited number of sexual assault nurse examiners in the state. And so often people either have to wait hours to be able to have this exam or drive hours, or often they just go without having the exam. And it's something that they've built out a whole team of expert SANE, sexual assault nurse examiners, that are able to bridge to these rural underserved hospitals to provide that service remotely. Same thing's been done in Van Horn, Texas, that their ICU was going to close down. They couldn't staff it with the right level of providers. And they were able to create a tele ICU that by having connection to these specialty providers, that they're able to coach and direct folks from a distance. How many of you have in COVID used an on-demand telehealth service? Teladoc was one of the first and the leaders in the field in this, that they are serving over 20 million members at this point. And I have to bet that their response time has decreased as they continue to staff up, and people like it. This is, again, thinking about the advances and the wearable devices and the ability to communicate that back, to have a link back to your healthcare providers, that these devices can start to monitor and interpret data for us to make better decisions and get care to people faster. The other part where you need technology for is the rate of knowledge doubling. All of medical knowledge doubles every 73 days. And then we're going to have, with all of these devices and sensors, we're going to have more data. And there's going to be a huge need to be able to figure out how to manage that data. Anybody want a Coca-Cola, Sprite, Dr. Pepper? What's your drink of choice? Now, this is what our healthcare looks like. Same kind of deal, on demand. This is a project at Texas A&M as well. This is from a company out of Florida. I don't know if anybody else has heard of OnMed, but you can step inside all of the ancillary devices, your otoscope, and it's got, will drop out of the ceiling. You've got a nurse that pops up on screen, same way you sit down in a doctor's office and they take your symptoms, and then collect the data that they need and report that back to the provider. Then you wait for a minute and get to watch this really cool video about the provider and where they went to school and what their specialties are. And then up pops the provider. So for when there's concern, so some things can be done video conference only, but when you're needing those extra tools or you're needing the internet connection, I think this may be something that we see. And then on this left-hand side is actually a pharmacy. So whatever their like most common formularies are included in this dispenser. And so you can walk in. They even have pretty good reliability in diagnosing ear infections from the thermal cameras. And leave right away with your antibiotics. So there's some exciting stuff in store with telehealth. Let's talk about terminology. Terminology in this space is a mess, honestly. You'll hear telehealth, telemedicine, telepractice, mHealth, eHealth. Trying to figure out what each of these means can be difficult. But this is one of the common definitions of telehealth. Again, thinking that it's not just the delivery of healthcare services, that and it can include the use of electronic information to support and promote healthcare. Even in education, public health, health administration. So it's not just the service delivery components. And so usually you just get tele and the specialty. So if we're talking telemedicine, then we're talking about prescribers, often physicians, telebehavioral health, telemental health, teledermatology, teleradiology. You get the picture. This is my personal soapbox I have to give in every lecture. So I'm sorry, I'm going to step on and then I'll step off. I think we're really struggling by using face-to-face incorrectly, frequently, or just it's not as specific. That face-to-face could be over video conference and you're two people face-to-face looking at each other. I think the more accurate way we could move forward would be if you mean in person, please say in person. Face-to-face is just less descriptive. So off soapbox. Everyone here changed their language to in person. I'll be a happy presenter. Here's some examples of modalities of telehealth and some terminology: synchronous and asynchronous, you may hear, or real-time and store and forward are two ways that those are put. So obviously real-time synchronous is we're getting feedback immediately. That's your video conference, your telephone calls. Store and forward, that's your emails and text messages, your teleradiology. They've taken an image and it's being shipped off for someone to review. Remote monitoring, have used that for a while. In this presentation, talking about the sensors and wearable devices. And mHealth, if you're curious, is supposed to be specific to mobile devices. We've got all kinds of tools to use for technology that count as telehealth. So just trying to kind of broaden your mind away from, most of us have probably done some video conferencing health service at this point. All right, benefits for patients. So literature talks about these 4 barriers to treatment, the 4 A's. Acceptability. What's the patient's attitude towards healthcare? Affordability. What's the cost? Availability. Are there providers? Are there clinics? Accessibility. Can they actually use it and get to it? Can you guys think of some ways, have these 4 barriers impacted you and your practice or your life that you'd be willing to throw in the chat box? We haven't been super active in the chat today. I think I see all of these very frequently in the practice that we run, that most of our folks do not have insurance, often maybe unemployed or on disability services, serve, many minoritized groups with strong stigma against mental health services. I've already talked about the dearth of mental health services available here in Texas. So the point of this talk is to talk about how telehealth can provide answers to that, this move towards person-centered care, and you can meet on your terms and your time, I think has the potential to increase trust with providers, perhaps to overcome stigma, not having to travel to a particular clinic or place, especially in small towns where everyone can see that you were at the psychologist's office. They know what car you drive. That being able to access services from home can improve and reduce stigma. Can minimize the additional costs of like travel and gas and hotel stays and things like that for having to travel long distances, sometimes for services. There's a big debate about whether, overall this dramatic increase in care for the bean counters, whether it's going to increase the cost for the system as a whole, or whether there'll be some kind of right sizing that if you can get people care when they need it, when and where they need it, that it will balance the system out as you're paying less for, emergency and crisis services when folks are managed better on a daily basis. So, thinking about that hollow medicine slide, we've still got a long way to go. And if you're a provider or worked with an EMR, or you're a caregiver and you've tried to be on the patient portal side, we've got a long way to go on making technology easy to use. I think that the significant uptick in telehealth because of the pandemic will help with that. But there is a lot that has been done. Most of us can tackle obviously you're here on Zoom today. So, and as that becomes just more and more commonplace, then I think we'll just continue to see technology interwoven into our healthcare. This is one of my favorite things about switching. So for a long time, we had the hub and spoke model. for a variety of reasons, mostly internet and devices. We had to have a Cisco high definition video conference unit, and it had to have a strong internet connection, T1 lines like dug and built out to these facilities to get the services there. We've come a long way since then. Also, wanting folks to get out of the house. Each community kind of decided where they wanted them to go. So they would be in resource centers or in primary care. So folks had access to other social service or health resources while they were there. And now we have technology that can be used cloud-based. So you can use it from any mobile device. And it's really been great to see that shift of folks being able to have services on their time and in their space. I would like to see both the hub and spoke and direct to consumer models continue. I think that we will need bricks and mortar in certain times and presenting concerns. But yeah, just think about some folks coming to therapy to address concerns of trauma. And they can turn their lights down low and bring their dog and put their essential oils on. And they've now created this space for therapy that they never would have gotten having it come on the provider's terms to their office. There's lots of evidence to show how telehealth is able to overcome or at least reduce some of the disparities in access for some of our underserved populations, making it easier to get to services. Again, these ideas of having some anonymity, not having to go to a place, the person-centered aspects, I think all of those come together to help reduce those disparities. It's probably my second favorite part about telehealth that I can't wait to see how this grows, is being able to connect specialty care to specialty needs. That in rural areas in particular, you have to be a generalist, be ready to see anything. And often one of the reasons why it's hard to recruit in an underserved area is the lack of referral sources. And then feeling the burnout and the pressure that comes from working to treat everything that comes into your door. And so I think as telehealth grows, being able to connect patients and people to specialty services is pretty exciting. Benefits for providers. It does depend on what kind of healthcare you're providing. But, I think about the telehealth platform that we have here at A&M as staff and faculty. I several times during the pandemic have gotten on a call in less than 2 minutes with someone to get something looked at for one of my kids. And I think, wow, how quickly they can turn over patients and see more patients. Doesn't really work that way in behavioral health. Therapy is therapy. It's hard to double book or overlap people. But in certain circumstances, it can certainly increase the amount of patients that someone can see, decreasing the overall cost of services. And if the personnel cost is followed closely behind by square footage in terms of operating costs for any program or organization. And so as they're able to cut down on square footage cost by not having to have all their providers in one location, there's some promise there. So when we're providing services to someone's home, we get new information. Folks come to their appointments alone or with one other person. We have no data about their home. I think about, this may be silly, House. If anybody's seen that show where they're diagnosticians trying to figure out, what's really going on that's contributing to what's presenting in front of me right now. One of the first things I always do is go to someone's home because there's so much good data there and stuff about the environment, their family. That also comes with the burden of the noises and distractions and trying to work with folks that don't have a quiet place for a session. So it is an adventure providing services direct to people. I've always thought that's been interesting about the pandemic. I really value that hub and spoke model, and the parameters that provides for someone to be able to go to a facility for their services. And then we have a whole slew of providers just all of a sudden providing services on the I've had talks called like in home, the last frontier. And we all just ran straight into the last frontier, but I think we've been doing a pretty good job. I think there's a lot of potential for the inclusion of caregivers with technology, because the data from the patient and the caregiver is valuable, and it's different. My dissertation was on trajectories of happiness for individuals following acquiring a severe disability, traumatic brain injury, spinal cord injury. And I had this a variable of the insider and the outsider, like, well, how did the person report about their happiness and how that changed over time of 5 years, and how did the caregivers rate that? And there is, we found a significant difference. So that having both of those data points is great. A lot of the healthcare system, though, and technology is not necessarily configured for that. So if you're a provider, having this consideration in mind when you're thinking about technology tools. If you are a caregiver or a person with a disability, advocating for these things, that they're often set up point to point, provider to patient, and that pushing for having the caregivers in the loop for text message alerts and patient portal things, that those options be made available to include other important people in that person's care plan. And same for the telehealth platform. So maybe not even like, you may not even be in the same physical space as with that person at that time. And that's difficult. So we run a lot of groups, and like our EMR that we have has a telehealth platform, but again, it's configured for patient to provider. And so it doesn't allow you to add multiple endpoints. So it's not good for groups. It's not good for including other people in the care, in the care plan. Limitations and risks. Okay. I mean, you get limited data, unless you have those, ancillary devices and blood pressure cuffs and otoscopes and things that you're giving to people to use those, and give you the data back. That there's still a gap there. So we've got video conferencing down pretty well, where within the scope of practice, if you can collect information and self-report about it and make a reasonable diagnosis and treatment plan, then we're good to go. But it just changes what you've got in your eye contact, what's happening with the rest of their body. Just the grimaces, the tears, the nuances and facial expressions can sometimes be lost. So a lot of that just has to be verbalized. And you have to ask more questions out loud than typically you could gather that information just by being with someone. But there's certainly ways around that. Back when we were paper and pencil and all in-person health services 20, 30 years ago, 10 years ago, how long ago was that? Before EMRs. The only way you lost patient data was if you threw it away like in a trash can and didn't shred it, or you went and ran your mouth and talked about somebody outside of their session. So, but once you introduce technology, and there's data moving from point to point, there is some level of risk about leaks and hacking and accidental exposures. So, but there are safeguards like HIPAA and high tech at the federal level. States often have additional regulations in place to help protect data, and telehealth platforms are typically created with that in mind. Errors in technology. I would love to know the economic cost of troubleshooting loss to provider time. We've got a lot of providers all over the country spending a lot of time helping people figure out how to turn their microphones on and off. So, and in some places, I mean, we've tried to build that in. Been doing telehealth long enough that trying to have someone at the ready to help clients and patients with their technical issues. has been helpful and important, but that's hard to figure out how to compensate for that time. But technical errors are going to happen. Internet's going to drop. This happens a lot in rural areas, but just, the strain we're putting on our broadband infrastructure with everyone moving remote. I don't know that was just a rural issue. So think about always having an alternate method of contact. So if that's, folks can expect to hear back from you by phone, or how you're going to, what your troubleshooting plan is something that you could put like in your information sheets. Or if you're a caregiver or when you're a patient yourself, asking for that ahead of time of like, so what do we do if this doesn't work? What's the backup plan? Just some key bits of information. The quality of any video session or connection is determined by the slowest transmission and the lowest quality hardware. So again, that's to me another argument for hub and spoke. It's great to have a place where folks know that in general, the equipment that you need is there and there's a strong internet connection. So both sides matter. Weather matters, especially when there's wireless communications involved. Our webcams have limitations, so help them out. They have to take apart and put back together every pixel. So by giving proper lighting, limiting your movement, having a plain background and plain clothes really can make a difference in the quality of the transmission between you, because it's not having to unpack so many kind of unique pixels. All right. What do we know about telehealth effectiveness and trends? We have a lot of literature about video conference services. This is specific to mental health, but we've got small case report and trials. We've got randomized control trials, gold standard. We've got systematic reviews, meta-analyses across diverse groups in diverse settings, all showing that there's not a patient subgroup that we've identified that doesn't benefit from or is harmed by mental health care provided through remote video conferencing. So that's something that we can rest assured of. Although my caveat to that is always, your telehealth is only as good as the person on the other side. And so going with trusted healthcare providers first. There are a lot of pop-up telehealth companies of varying quality, perhaps. So use your common sense too in selecting care providers. There's evidence of provider bias against telehealth, just reluctance, both from, feeling like, okay, can I really maintain my scope of practice and do it ethically and do it well? If I'm not in person in the same room as my patient. This was an interesting study that showed, so it was 2 scripted therapy sessions. So the session was fake and it was exactly the same. And then the participants were all randomly assigned to watch one video or the other. So one group watched the video of this therapy session and it was in person. So the 2 people were in the same room, could reach out and touch each other. They hold this counseling session. Then the other group had to watch a video of a telehealth session. And again, same script. And then the participants had to rate the session. They had to say, okay, well, how effective was that therapy session? And how good was the relationship and the alliance between the 2 people? And there were significant differences between the in-person and the telehealth group that folks who watched the in-person video felt like the alliance was better and the relationship was stronger and that the therapy was more effective. So there's something kind of inherent in us to be doubtful about, do our interventions translate across a distance? And so just having that in the back of your mind, that most of us carry that with us unconsciously. even if we're big proponents of telehealth. And there is a lot of literature about therapeutic alliance and satisfaction. How strong is the relationship, and shows that you can develop a strong relationship. Again, I mean, there's so many different elements that go into a strong relationship and a good alliance with your provider, with a patient, that I think stems beyond the modality of whether you're seeing them in person or by video. And the research supports that, even for phone counseling, where you maybe can't even see the person. Phone counseling is that'll be a big debate about whether we can get reimbursed for audio only things going forward. But I do think that we'll probably see reimbursement for video services going forward. Yeah, so people are very interested in easy access. So this was pre-pandemic. 30% were already using computers and mobile devices for medical information. But almost 3/4 of people said they are comfortable communicating with their provider via electronic means, text, email, video, instead of seeing them in person. And that they really prioritize access to care over the need for human interactions with their healthcare providers. And most said that they would utilize telehealth services, and most of us probably have this year. Telehealth is booming and will continue to boom. We need some updated figures post-COVID. I think we're awaiting decisions about continued reimbursement. Looks like we just got a great link in the chat for if you have further questions about billing and reimbursement, that they've got a link there. Okay. Now so you can count this as ethics, because everyone wants to count ethics. We'll make sure we cover this. So there are ethics, codes, laws, and guidelines. And as that relates to telehealth, I think if you're going to do telepractice, each organization has an ethics code. They can be both aspirational and enforceable. Often ethics codes start with an aspirational section and then have other codes within them that someone could file a complaint with your professional organization about. And many of those don't mention telehealth specifically, and I don't know if that'll change, but always worth a reread with telepractice in mind and thinking about, do any of these ethics codes, am I more likely to have a dilemma related to any of these codes if I'm practicing via telehealth? Laws, absolutely enforceable, created by legislative bodies, and these do vary, and there are some that mention telehealth by name. And so knowing in your state what telehealth laws are there is important. And then guidelines. So we're starting to see more professional organizations, typically are the ones that put these out, that say, hey, here's your suggestions for guidelines and best practices. They are aspirational, they are not enforceable. So looking to see if your profession has telehealth guidelines available that can help inform your practice. And at the end of the day, all the ethical and legal standards of care still apply to distance work. So there's no magic thing that happens that once you're on telehealth that you don't have to abide by your laws and ethics codes. So, and on the patient side, I think resting assured that like the same quality of standard of care expected of your health professional is expected via telehealth. One of the issues that can arise is competence to treat, and just making sure that you're providing services in which you have proper education and training. Obviously, if you didn't know how to treat it in person, again, no magic. So don't do it via telehealth. Consult the literature often and consult other professionals who are working with that particular presenting concern or that particular population via telehealth, and learning kind of the intricacies and nuances of that type of work. I think I've sprinkled this in pretty well throughout, of that there's different challenges in home versus hub and spoke. we were probably before the pandemic 90% hub and spoke and 10% in-home. And when the pandemic hit, that turned on its head. So we were 90% in-home and 10% hub and spoke. And we absolutely increased our exclusionary criteria, or were more particular about who is eligible, because in the home they have access to means to harm themselves, access to substances. The handling of emergencies becomes a little different in home versus hub and spoke. Location matters. You can only serve people where you're licensed, and different professions may have different rules about this. Often in many professions, you need to be licensed in the state where the patient's feet are. And in some cases, in some professions, you need to be licensed in the state you're sitting in and the state where the patient is sitting in. So you need to know what's legal. And I mean, the first question, and our patients just know it, hey, I need to document your location. Where are you having your session today? That's for in case of emergency, and to make sure that you're not practicing outside the boundaries of your license. Lots of professions are coming up with interstate practice plans, where it's like psychology has one called PsyPact. You can apply, and once you have an e-passport, you can provide services into any other PsyPact state. But then you need to be thinking about whether it's what does your interjurisdictional compact say, or what does each state say? Like if you're going to start practicing across state lines, whose rules trump whose? Which ones do you follow when it comes to things like reporting child abuse, elder abuse, duty to warn, and that varying across states. What are the record keeping requirements? Are there telehealth training requirements for that state? And then checking with your liability insurance to make sure that they're also going to cover your in-state practice. So it is a little bit different. We don't get to pick folks up in the waiting room. We miss out on some of the gestures. We talked about this. Some of the benefits, though, are the improved ecological validity, getting to see where people exist and the spaces that they live in. And I think this is my last slide, and then I think we'll have some time for questions. But these are just some of the considerations that we have in going into a telehealth session, that we really want the patients to be in a private space. That's tricky. It's tricky in so many different scenarios, from college students with roommates to large families to low-income families. The issue of like I'm having an undocumented status, and being concerned about, okay, well, if our rule is that if you can't keep yourself or others safe, I'm going to send emergency support resources to your home, folks who don't want that sent to their home. And so we've gone round and round about, finding other safe spaces for therapy. Is a picnic table by a tree an appropriate place for therapy for this particular person with this particular concern at this particular time? That's kind of always what we're running through, and thinking about that. Confirming the address and verifying phone numbers. Some of this is to do every session. Some of this is to do kind of in the first session. And again, whether or not this is another additional cost. Like, if you were really going to have all of these things set up beforehand, should it be the provider that's taking the time to do this, or maybe a support staff person, but then knowing that's not reimbursable time at this point. But again, making sure patient has phone numbers, provider has phone numbers, and having an emergency plan of mental health emergency or physical health emergency. You have your first seizure, or I don't know, blackout, have a heart attack. What can you expect that we're going to do? And sending out emergency response. Review the limits of confidentiality, which is really kind of just, my spiel is like what I said earlier of, if we were in person, the only way your information would get out is if I went and told my neighbor. But now there's technology involved, and there is the potential for breach. However, we have a HIPAA compliant medical record system, and my telehealth platform I'm using is HIPAA compliant. That was waived by and I believe still is waived by the Office of Civil Rights in terms of needing a HIPAA compliant transmission modality that you could use FaceTime or Google Hangouts. I would be really surprised if that stayed around for much longer. So plan ahead, get a good compliant connection. Discuss emergency plan, and hey, let them know what's going to happen if you get disconnected. I'm going to try and call you back. We'll troubleshoot for up to 10 minutes, and then we'll have to reschedule. Our backup is to discuss by phone. This is the number you call, or I'm going to call you back. Just you'll alleviate a lot of headache if the patient and you knew ahead of time what's supposed to happen when the tech issue happens, because they will happen. Review risks and benefits of telehealth. That's something we do in our information packet up front. That's not something we do every session. Just review the nature of the services and limitations, at which point you're not going to be able to meet this need via telehealth, and where they would get those services elsewhere. Establishing clear boundaries of use. When and how can the patient contact you? What's your no-show policy? A lot of times once you start getting these telehealth platforms and your EMRs, they may have messaging systems built in that folks can log in anytime and send messages. So setting expectations up front, again, probably in the paperwork of like, if you submit something through a portal, you can expect a response back in 24 hours or 48 hours. And document. We just have a standard template that says like these are the things that we did with this patient, and sign off that it was reviewed. So concluding points for providers: keep up the continuing education. Thanks for coming today. The reimbursement advances are promising. There's a lot of other resources available if you're wanting to get into the telehealth space. So each region, the state's broken up into regions, all have a telehealth resource center. So find yours. The Center for Connected Health Policy is another great resource to keep up with policy changes and reimbursement updates. And if you haven't started telehealth yet, I always say think of a pilot. Think of a need you have in your practice. Think of the 4 A's and which your clients and patients are experiencing most, and how could you use technology to help improve that. For caregivers and patients, can reduce burden and access. Meeting with providers far exceeds going without care. So if you've been putting off your appointments, look for your telehealth options. Use your trusted providers first, and treat your telehealth visits like an in-person visit. So be ready, have your questions, wear pants, don't bring your Jack and Coke. All of those things are good. And that is the conclusion of my presentation. Are there any questions?
All right. Well, please, if you have any questions for Dr. McCord, please post them in that chat. And Dr. McCord, thank you for a great presentation on telehealth for our providers and caregivers that are on. This is really informative, and I was already thinking about things because even in our setting, how telehealth has just taken over in the last year. I'm a caregiver to my mom, and she has cancer, and so it's been interesting to see how her hospital, MD Anderson, is doing services through, they have an app that they use on their phone, my mom does, and so she communicates through messages, and then she's also been doing in-person care as well as virtual appointments with her providers. So it's been really interesting, and they are in rural Texas, and so sometimes her care is better than other days. So it's interesting to see this evolve over time.
Yeah,
As
thanks for
we,
sharing.
yeah, as we begin to close out, if we can go to the next slide, for those of you that are interested in receiving continuing education credit, whether you're a social worker, case manager, patient advocate, a certified family life educator, or if you're just needing a general certificate of completion to provide to your supervisor for attending today's session, we are providing all of that information. You will need to go to our event page and give our team just a second to get that link posted, but you'll scroll down on the event page to continuing education. You're going to see a nice purple button and you will be able to select that. And I'm going to post that link into the chat pod as well. So if you're interested in continuing education credit, I'm also going to post in the chat my email address. If you have any tech issues with receiving your automatically generated email certificate, please do not hesitate to contact me. I will help you with that as well. And if you have any questions after today's webinar that you think of that you wish you would have asked Dr. McCord, go ahead and send me an email to the email address posted in the chat as well as on the event page and slides, and I will be happy to pass along those questions or comments to Dr. McCord as well. So we really appreciate you guys attending today's session, and also very much for Dr. McCord presenting on this very timely topic. Um, Also, stay tuned next month, June 30th. Mark your calendars. We are going to be doing a special webinar on individuals with special healthcare needs and getting ready for back to school. It's already crazy that we're close to ending a school year, but then before you know it, we're going to be getting inundated and preparing for back to school. So join us on June 30th as we look at recapping our school year of COVID-19 and how individuals with special healthcare needs, their teachers, their providers, their parents navigated this past school year with challenges. And then we're going to look at preparing, how we can prepare providers, students, and caregivers as we think about a new school year. So stay tuned, join us June 30th for that webinar as well. It's going to be called Back to School 2020, Getting Ready for Virtually Anything. So we're going to be looking at how we can reintegrate into a new school year after COVID. So join us for that really great webinar coming up next month. Stay tuned for all of our upcoming events throughout the Learning Network. Get connected with us. We're on Facebook, Twitter. We send out lots of emails, which is why you guys probably are on today, is because you've received an email from me about our upcoming webinar. So stay tuned, join us. We're going to stay on the Zoom for a couple more minutes. We're at the top of the hour, but if you have any questions, we're going to stay on for a couple of minutes. Feel free to post those in the chat and gather any last minute links in the chat pod. So thanks again, Dr. McCord. Thanks again, everyone, for attending today's session.